Dr. Moore, you've spent 25 years studying testosterone, from fertility to cardiovascular outcomes, running clinical trials, publishing extensively. When you zoom out on this, how would you say the story of testosterone has changed over the years?
Jack, first of all, thank you for having me on the show. And, it's been an amazing ride for me because when you look at testosterone, there are categories we call safety and efficacy. When I started my fellowship, we were taught that testosterone causes prostate cancer. It's like putting fuel on the fire. And if you look at what happened over the past 25 years, we've had a complete paradigm shift. We've shifted from dangerous to possibly safe to now therapeutic and probably even potentially beneficial. So it's a complete 180 when it comes to prostate cancer. And the exact same story is for cardiovascular disease. First, we thought it was beneficial. We thought that it actually could, low testosterone increases cardiovascular risk. Then there was a segment of time for 10 years where we thought maybe it increases cardiovascular risk. And now we're back to knowing that due to many trials like the Traverse trial, it doesn't increase cardiovascular risk. So it's been a roller coaster, but it's been an exciting roller coaster to see all these changes occur over a 25 period span.
And I think you have been right and early for a lot of this, haven't you?
I have.
Where you've maintained this position when maybe the tide has gone against you for a lot of it. How has that felt at times?
At first, it was very difficult because the reality is I was just starting my career. I had just finished my fellowship, and I put out the largest paper at that time. It was in 2007, giving men testosterone who had a history of prostate cancer. Many of even my own colleagues and my partners said, "Are you crazy? You're going to make them have their cancer recur." But we kept on pushing. I'm very good friends with Dr. Abraham Morgentaler, who was one of my mentors, who was about 10 years ahead of me, and he was also pushing. So together, it's been a great journey. And, there have been numerous trials since. I published that in 2007, also showing that testosterone does not increase the risk of prostate cancer recurrence or progression. But at the beginning, it was tough. It was very tough.
Sure. And I think the saturation model is something that we could refer to later on, if that's all right with
Yes,
you.
very important. Yes.
Yeah. I would like to start at the top with the notion that if you ask a man in his 30s, maybe somebody like me, to go and get his blood pressure measured every year, probably not going to rush to do that. What's the point? I'm not interested in that. But if maybe a man like me has ED symptoms, they're going to see you straight away. They're going to run to you. Is there maybe something that we could put out and suggest to people who in their heads too young to have any problems to
Yes.
actually go for those tests and maybe think of sexual health as an early warning sign or an early marker of why does
Yes. Jack, this is such an important point. I'm glad you're bringing this up because the reality is that erectile dysfunction is not a disease. It's a symptom of something bad going on. You call it a check engine light, meaning that either you're suffering diabetes, depression, cardiovascular risk. There are numerous studies demonstrating that if a man has erectile dysfunction, he's much more likely to have a cardiovascular event. In fact, 15% of men will have a cardiovascular event within 7 years. It's quite high. If a man has erectile dysfunction, he's much more likely to have occult diabetes, 30% chance he has underlying diabetes. And we also know that men who have ED are much more likely to suffer from depression and anxiety. So the biggest mistake you can do, I tell my colleagues, is when the man walks in with erectile dysfunction to just hand him the Viagra and say goodbye. Because all you're doing is allowing that disease process, whether it be diabetes, cardiovascular disease, whatever it may be, to get worse from year after year after year, so that when you finally find it, whether it's a heart attack or uncontrolled diabetes, that patient has taken that hit for so long. So I say to them, that's the time to capture them. And you're correct, Jackie. I remember when I was 30, there was no way I was going to go in for an annual hypertension screen or annual blood pressure or a sugar screen. I was invincible. But if a young man gets ED, he is at my front door tomorrow morning, ready to be seen because he's like, what's going on? So I tell my colleagues as well, ED is the gateway to men's health. He may not come in for hypertension and he may not come in for his sugar screen, but he will come in for ED and you stop and you screen him and take care of him and counsel him then because he's right there. So it's like a golden opportunity. So I do say that ED is a gateway to men's health and to screening men for men's health. But ED, again, very important. If you're suffering from erectile dysfunction, it is a symptom of something else going on.
You call me out if you have noticed this
Sure.
in other areas, but you have something where you can treat a symptom, which massively impacts a person's kind of spiritual health, emotional health, social health, and potentially save their life, maybe increase the quality of their life as much as anything else, just by addressing something that a lot of people would be embarrassed to talk about.
I couldn't agree with you more, but you have to think about, there's two ways to address this problem. One way to address this problem is to put a Band-Aid on the problem, which I don't really approve of. The second way is to go and treat the underlying problem. I'll give you an example, Jack. Let's say today you broke your leg, okay? I have two choices. I can actually fix your leg, or I can give you a painkiller that you can take every day, and you can continue to walk until the painkiller stops working. So Viagra is a painkiller. It's not a cure. It's a Band-Aid on a problem. It's just waiting for the disease to get worse and worse and worse till the Viagra stops working, right? But if I said, Jack, let's go to the core. Maybe we go to the 4 pillars: diet, exercise, sleep, and stress reduction. And again, I don't have a pill on the planet stronger than diet, exercise, sleep, and stress reduction. Each one independently can reverse erectile dysfunction and sexual dysfunction in men and women, right? So maybe we go to there. Maybe you have an underlying depression. Maybe you're suffering from anxiety. You go for the cure. So the cure is not the Viagra. It's to find what the underlying problem is. And maybe it's your testosterone level. It could be a contributor. So again, I think just handing the Viagra is a mistake. We want to go for the cures.
I think there could be a bit of jumping around just because there are lots of ideas I've got here popping off, and one around the Mediterranean diet, which I've not discussed with anyone yet. So I'd love to get your take on it maybe a little bit later on. But the notion that you have a vested interest as an expert in testosterone, you lead the Testosterone Project, is that right?
Yes, that's exactly right. I'm on the board of the TPP. Yes, exactly right.
So, this is something that you'd like to see use of and safe use of. But when I look at your interviews, when I look at your writing, you are pushing those 4 pillars. You are pushing everything hard.
Yes.
Why is that? How come you're pushing lifestyle for somebody who has this interest as a professional?
Yeah. So this is what happened. I started treating men. I've been treating them for now 20 years, and I would have them come in, and I can't tell you how many people would come in. I'd hand them the Viagra, I hand them the testosterone, and they'd leave. And I did it year after year after year. And it got boring. It got really boring. And I said, there's got to be more than just this. And a personal story, at that time, I was about 30 pounds overweight. I was not sleeping. I was working crazy hours, stressed to the max, and it was very difficult to exercise. And so when I would tell patients and see patients, I said to them, I started saying, I'm going to start getting into lifestyle modification. And I say, you should exercise, you should sleep. But you look at your doctor, and if they are 30 pounds overweight and they look exhausted and stressed, it's hard to take them very seriously. So I started living the 4 pillars about, I'd say 15 years ago, and it's changed my life. I mean, it's absolutely changed my life. And when I started integrating that into the patient care, I tell my patients it's synergistic. I will take care of your hormones. I will take care of you medically, but that's only 50% of the story. If you can help me with diet, exercise, sleep, and stress, it becomes very synergistic and you really take off. And I see it over and over and over again. And those patients are so much more grateful and so much more appreciative than the patients you just hand the Viagra and the testosterone to. So the impact of lifestyle modification with modern medicine is incredible. I can't tell you how gratifying it is and how much you see an improvement in their quality of life. But remember this, I'm not just helping their sexual function because I specialize in sexual function. I'm increasing their lifespan and their health span. It's the whole package. It's not just their sexual health.
Sure. And I'm just wondering, as an idea, if you already feel maybe emasculated, you feel a little bit cut off because of this thing that we don't talk about. My experience a year ago, I was training hard. I'd just done a half marathon. I was in good shape. Business was in a good place. Like, I didn't really have any anxieties, but something felt off, Like, I've been depressed and dysfunctional before, but this was the first time that I felt depressive while being really functional, and I couldn't quite figure it out. And I spoke to my GP, and he prescribed sildenafil or something like that.
Yes,
that right?
Viagra, same as Viagra. Yes,
Perfect. And gave that a go, but it didn't really make a difference for me, And so then I was thinking, okay, cool. So it's not necessarily, I don't know what this is, but that isn't the cure. I still felt off. It didn't change my sexual function or experience. So then I was questioning, my hormones for the first time. Am I at a point where, actually I've got low testosterone? It's not difficult for me to get that checked. So I did my bloods, and I sent them off to 2 places. I had an online clinic in the UK that's fronted by quite a prominent fitness influencer, and the NHS look over them. And the online clinic kept on emailing me with discounts, subscription offers to treat my testosterone, and the NHS said they wouldn't go anywhere near it. The NHS said, no, this is on the low end of normal, but it's still in the normal range. So, we won't touch that. Now, I could pay for it if I wanted, but that didn't seem to me to be the right thing either necessarily, that I could have this exogenous help, but what was missing? And maybe that's something that you can talk to specifically because you have, clinical experience of that. But what worked for me, and it might not work for everyone else, is that I redressed my relationships with my family and my friends. I trained a little bit less, ate a little bit more, and actually found somebody who could give me a hug every now and then. And you know what? After that, things got a lot easier. So I've just said a load of stuff at you there that's quite
I love it, though.
personal,
That's
but
an amazing story. We talked about sexual dysfunction as a marker of overall health, but so is testosterone. So we know, I don't know if many people know this, but, testosterone has been implicated or associated with erectile dysfunction, low libido, muscle mass, fat deposition, energy. That's great. And those are wonderful things that will improve your quality of life. But let's step it up a little bit. And let me explain to you another facet you may not know about. Did you know that men with low testosterone levels are much more likely to have a heart attack? Period. Non-negotiable in every major guideline. British Society of Sexual Health, US, every society. Men with lower testosterone levels are much more likely to have a heart attack. Period. Men with lower testosterone levels are much more likely to break a bone. Osteopenia, osteoporosis. Men with low testosterone levels are much more likely to have depression. It's a big study that I did, and we can talk about it, but they're much more likely to suffer from depression, and giving them testosterone can improve their depressive symptoms. Men with low testosterone levels are much more likely to suffer from diabetes, obesity, and metabolic syndrome. And finally, men with low testosterone levels have been shown in numerous studies to have increased mortality. They're much more likely to die, right? So you show me another blood test, Jack, any blood test in the world that's a better predictor of a man's current and future overall health. It's testosterone. There's no other blood test, right? It's not his hemoglobin A1C. It's not his thyroid. Testosterone is the single number one best predictor of his current and future overall health. And every man over the age of 40 should be screened every single year. In fact, we are now wanting to drop that number down to 30. Every man should be screened every single year with a simple testosterone blood test to evaluate his current and future health. So that's a really important message to realize. But you did something in your story. You actually took lifestyle modification very seriously. You said, I took the pill. It didn't do much, but I started going out and feeding my emotional health, my mental health, and my physical health. And as I did that, things got better. And that's the part I was trying to talk about earlier. It's not just about the pill. The lifestyle modification in many cases is much stronger and much more powerful and a cure, particularly in young men, because why would a young man like you in his 30s start having erectile dysfunction, right? Sometimes it's psychogenic, it's depression. It's very rarely is it organic. It could be organic, meaning there's an underlying cause. If you're 50, much more likely, but you're a young 30-year-old man that's in great shape, right? So your story resonates with me very well.
Yeah, no, I appreciate you saying that. And maybe a little bit of context for you as to why I wanted to push the pillars, because what you're describing as your 4 pillars tie into the 6 pillars of fitness and thinking. It's that fitness is broader than physical and mental health. It is the emotional, it's the spiritual, it's, this stuff that we're tapping into. The TRT, if I were to go through the private clinic, would impact my financial fitness. There would be a very real cost to that. And then another concern would be, without having necessarily the education or experience around it, would I be on that for life? Would there be a necessity once I start to stay on it? And that was a question that I didn't really get answered at the time. But the final piece of the puzzle, Dr. Mo, is there are 2 people very close to me in my family who have both had prostate cancer warnings. Now, one decided to go on the wait and see route, and the other had a full prostatectomy. That's right.
That's right. Remove the entire prostate. That's correct.
And obviously there was a period of recovery needed for that. And I think that the latter relative feels fairly comfortable now, fully recovered, back to lifting things, back to exercising, life seems to have carried on. And then wait and see, I think there's still an anxiety there. There's still a nervousness about it. And neither of these will go on TRT for fear of cancer risk, for fear of making things worse. So that's part of the reason why I took a step back and looked at alternatives. Does that make sense?
It makes sense, and it's what it's expected. We were taught in medical school that testosterone, again, is adding fuel to the fire. 1941, the early 40s, Huggins and Hodges were writing papers, and their early work showed that testosterone increases the risk for prostate cancer. It was based on one patient in 1941, and since then we've had this tremendous amount of fear that testosterone increases the risk for prostate cancer. And you know, and even when I was in medical school and even my residency, we were taught the same thing. So it takes years to change dogma. But the reality is that if you look at the studies that are coming out now, larger studies showing that no, giving men testosterone after radical prostatectomy does not increase prostate cancer risk. And you're talking about something called active surveillance. Active surveillance means I have cancer, but it's such a low risk that the reality is I'm going to observe. And that's a smart move because we know that most men who have low risk prostate cancer will die from something else. Jack, if you and I went to the morgue and we did an autopsy on the men who passed away, anywhere from 1 in 6 to 1 in 3 men will have prostate cancer, 1 in 6 to 1 in 3, but they just died from something else. So why would you take out their prostates? Why would you potentially make them incontinent or have erectile dysfunction if they didn't need it? So that's true, active surveillance. But let's even take it a step further. Let's say that your family members, one who had the radical prostatectomy and one who was on active surveillance, had a very good, normal, healthy testosterone level, okay? We wouldn't make them take away their testosterone. We'd leave them alone, right? In medical science, if they're normal, we tell them just keep it normal. If they're low, we say, I'm sorry, I can't replace it because it's dangerous. Well, you have to choose. If it's dangerous, then make everyone take away their testosterone. If it's fine to have a normal testosterone, let those who are low be normal. But we don't do that, right? And the reality is that the more and more we learn about this area, we're starting to get to an era where it's protective. Do you know, Jack, that if you had metastatic prostate cancer all over your body and you walked into Johns Hopkins University today, one of the treatment options is to treat you with high doses of testosterone. Fascinating. Treat you with high doses of testosterone to cause the prostate cancer to regress, to cause the PSA to come down. And they've been very successful at doing this. And you would have never thought, even 10 years ago, to giving high doses of testosterone as a treatment for men who have metastatic prostate cancer.
So I'm thinking along the saturation model here, does that link to what you've just said? And PET was the other thing that's coming up for me, but I might have
let's talk about both.
reading confused.
Let's talk about both. So the saturation model essentially says the following. We were taught that if you look at a graph, the more testosterone I give somebody, the greater the PSA. The more testosterone I give somebody, the greater the growth in prostate cancer, the greater the growth in the prostate. That's not true. We know that at a certain number, when you have testosterone, the PSA stays flat. So the example I can give you, and we believe that number is around 250 nanogram per deciliter. So Jack, if your PSA and if your testosterone was 200, you're below 250, and I give you testosterone, I raise your testosterone, your PSA will go up. It should go up. But let's say your starting testosterone was 290 above the saturation point. I could raise your testosterone to even 3,000, which has been done, and nothing will happen to your PSA. Nothing will happen to your prostate growth. It's saturated, right? So only at low numbers of testosterone do you see the movement in the PSA. At higher numbers of testosterone, it's saturated. And it's important to realize that because many patients who come into me with very low testosterone, say they come in at 190, I tell them your PSA will go up, but it will stop. It will saturate, and then it will continue to stay at that number. And all your body's trying to do is show you what your real PSA would have been. It's underestimated when your testosterone level is low. That's the saturation point.
Okay, amazing. I wonder if maybe we come back to the idea of what TRT actually is, because we're talking about raising to normal levels, aren't we? So
We are.
If we talk about testosterone replacement therapy, TRT, we talk about normal levels and maybe how it's skewed. You said that one person was involved in that study and that was a narrative that was carried for decades. How does that happen?
Yeah, so the 2016 endocrine guidelines had to come up with a number, and they came up with a number of 300. But to be quite honest with you, there's not a lot of science behind that 300, but they had to pick a number, right? And so that what they're saying is below that number, everyone is qualified for therapy. Above that number, you're not. And some people use that number stringently. They say, okay, that number is 300 nanogram per deciliter. But the reality is that everyone's different. We all have our own personal number. And so where you may be symptomatic at 290, may not be symptomatic until I am 350. We're all different. And we showed this in my laboratory. It's something called the CAG repeats. We've been doing this at my institution now for over 15 years, where we take the blood of all these men that come in who have low testosterone, and we look at the sensitivity of their testosterone receptor. And we showed that those men who have very sensitive receptors, they don't need much testosterone to feel much better. We showed that those men who have very insensitive receptors, they need more testosterone to feel better. We're all different. We cannot assume that at 290, everyone feels bad, and at 310, everyone feels good. It doesn't make sense, right? So I call it a range, and we use our best judgment. And some patients who come in, if they're at 350 or 360 nanogram per deciliter, I'll treat them for 3 months to see if they have symptomatic improvement. So again, I just feel it's important not to say that we have one specific cutoff. It should be a range.
For sure. And is this maybe two things here? A lot of studies are done on predominantly white folk to begin with, and
Yes.
a lot of studies will set out to find their own conclusions. I did a Master's of Science in Psychology, but came from an English literature background. And I managed to learn and understand, not least because I was a student trying to prove a thesis, how we might create a narrative to support the answer we're looking for, or the result that we're looking for, if that makes sense. So when we talk about that one patient, that one paper, and a narrative from there, you and I can see how that's quite easy to construct.
Yes.
And then when it comes to basing everything on one number, well, if that one number is just based on one demographic of society, that of itself is problematic.
That's very true. And you're absolutely correct that that's how the narrative can begin. Now, that number, I don't know if it was based on one race, but it was definitely based on one demographic society. The way we get ranges is that we take the patient population that comes into a laboratory, and then what you do is you then go and you look at the percentiles. And the lowest 2.5 percentile of that range of that demographic population is theoretically considered a cutoff. Now, theoretically, that if you look at the 2 point, that number should have been 350, not 300, right? But they still chose 300, so even less than the 2.5. But we know that many international sites, even the British have now changed theirs to 350, right? I mean, so we are seeing that many societies don't agree with that low number of 300. Now, the higher you go up on that number, the more inclusive you can be in getting the people who really suffer from the disease to catch them. But there will be some false positives in there. But I tell patients, there's no harm in a 3-month trial to see if this benefits you. At the end of 3 months, if you see no improvement, there's no point in continuing. I'm not here to treat your number. I'm here to treat you. And if you don't see an improvement, then we can consider not going on. But you did mention something earlier that I want to go back to. You mentioned that you had two options here, the NHS, and you also had a private company. But you're a very young patient to me. If you came into my clinic today, I would try to dissuade you from taking testosterone therapy because it will shut your natural production down. If you're trying to have children, it will make you infertile. And do I really want to do that to a 30-year-old and put him on that medication? And more importantly, the longer I put you on testosterone, the harder it is to rebound to back to where you were. So time influences the difficulty in coming back to baseline. So in someone like you, Jack, who's young and healthy, who has a low testosterone, if I could not find the cause, because that would be my first choice, then I would treat you with medications to help you raise your natural testosterone in addition to lifestyle modification, if lifestyle modification didn't work. But there are wonderful medications that I can give you that will help you make testosterone. So I wouldn't give it to you, you would make it. And that to me is much safer for younger men than to give them testosterone supplementation.
Obviously, there's always going to be caveats to stuff like this. We're not prescribing anybody anything. We're just talking about this as yourself with clinical experience
Sure.
and me with an interest in this. When you talk about medication that can naturally produce or help with testosterone, what does that look like? What does that sound like to a person who is new to this?
Sure. There are only 3 real medications that you can use, and only one is considered on label. So the other 2 are considered off label. But the one that's on label that's been around for a while is HCG. It's an injection. Essentially, the patient will take it 3 times a week, and it helps raise their natural testosterone. So a little bit of physiology in the pituitary in the brain. The brain sends a signal to the testicles. There are 2 signals it sends down. One is called LH, one is called FSH. LH goes to the testicles and produces testosterone. FSH goes to the testicles and stimulates sperm production. When you take exogenous testosterone, like testosterone injections or testosterone gels, it shuts down the LH and FSH. In other words, I tell patients it's shutting down the gas to the car, shuts down the gas, right? So the natural production goes down very quickly. But when you give HCG, HCG is just like LH. It's like the gas, right? So it basically gives the body more gas. And so the gas goes to the testicles and produces more testosterone. Sometimes off-label, we use a medication called clomiphene citrate. It's been around since the 1960s for women to help them stimulate ovarian stimulation, to help them become more fertile. Well, the same drug goes to the testicles and stimulates the testicles. It increases the LH and FSH. It increases the gas from the pituitary to make more testosterone. And that's a natural way. It's a pill, can be taken every day or every day, other day. But again, it's off-label because it was meant for women for fertility. But there are things that we can do if the 4 pillars are not effective to help stimulate the body to produce their own natural testosterone. But I really want to stay away from giving younger men testosterone if I can.
100%. And as somebody who works in gyms with people, the difference just increasing your steps can make each day to a person's outcomes. I want people to move more and in many cases eat more than they currently are, but just look at the things that they're eating. And the shadow of Mediterranean diet is still looming. We're going to address that, I promise.
Yes,
But
absolutely.
you've mentioned something there that I think is really interesting because I'm concerned more that we've maybe alienated half of the people who might listen to this. Off-label use for medication that was for women, testosterone in women. Can we bring this together? Because I think a lot of women might be listening to this and thinking, well, this isn't for me. This is a chat that I don't need to worry about. But that's not the case at all, is it?
Testosterone is critical for women. It is not only important for her sexual function, her libido, her arousal, orgasmic function, but we know data now suggests it's very important for cognition, muscle mass, depression, also bone mineral density, right? And unfortunately, in the US, we do not have a single testosterone formulation that is on label. You, fortunately in the UK, you have Androfem. You have a product that you can purchase for women if they suffer from low testosterone. And I think that's very important. In women, we talk about HRT. And when we talk about HRT, we're talking about estrogen and progesterone. But the reality is that women need 3 things. It's a triangle. That's the PET: progesterone, estrogen, and testosterone. And unfortunately, majority of them will only get the estrogen, progesterone if they're lucky, right? Many physicians are still reluctant to even give them estrogen, progesterone. But I treat a lot of women with testosterone. I've been treating them since 2007. And I can't tell you what an impact it makes on their own overall quality of life. And so when I treat them, I don't just use estrogen, progesterone. I use estrogen, progesterone, and testosterone because I do believe that synergistically they make a big difference. I don't know if you know a fun fact. Women make almost 5 times as much testosterone as they make estradiol, right? It's a very important hormone for women. And it just shocks me that, we cannot give this to them with a FDA-approved medication.
Is the issue androgenization?
Yeah, it's called virilization, which means that
Sorry.
she can actually get increased facial hair, acne. Very high levels can cause deepening of the voice, which can be irreversible. It's very high, or clitomegalia, which is enlargement of the clitoris if she has high doses for long periods of time. But the reality is that you don't see many of those symptoms if you manage the patient appropriately and put them into the normal range. If they're unmanaged or they have uncontrolled levels that are super, super high, yes, you may see those symptoms. But women do need testosterone. It is not a male hormone. We were taught that it's a male hormone from physiology because we say, okay, men go through puberty when their testosterone levels go up. It was always thought of as a male hormone. But women equally need testosterone. They make testosterone. They need testosterone just like men to have a fully functional, good quality of life. And unfortunately, most of these women are not given this very important hormone.
If you keep these 3 aligned and synergistic with each other, then that would minimize virilization concerns. I'm just trying to figure out why it is that we miss out that corner of the triangle.
Sure. You'd minimize the virilization if you decrease the testosterone dose. So the normal range for testosterone, think of it like women are 1/10 the dose of men, and they're also the range is roughly 1/10. So if men's range are 300 to 1,000, think of women as 30 to 100. Easy conversion, right? If I give a man a medication per day, use 1/10 for women. It's a very easy conversion. And if you give a woman higher doses than 1/10, maybe give her a half, maybe more, and some people do, that's when virilization starts, right? That's when you start getting in trouble. Not to say that some women at very low doses can get virilization, but we can actually mitigate and treat that. You can use spironolactone medications to help decrease the virilization. Some women say, I get a little bit of acne, a little bit of facial hair, but I can take care of it with electrolysis. I feel so good. I don't care. I'm going to keep doing it. I say, great. That's perfectly fine. So the low amounts of virilization many women can tolerate. It's the high doses of testosterone which cause significant virilization is where you got to be very careful. So it's a direct relationship with the testosterone.
So there's a nice pathway here that I can see. When should women ask for testosterone? When might they think to ask the question? And maybe what do they need to be asked to be taken seriously by a GP, considering that I don't know any women in the UK that would know whether they had low testosterone symptoms and whether that was a concern?
Yes. So a couple comments. It's changing in the UK. The UK now is really changing in terms of the education they have for women. I don't know if you know my good friend, Louise Newsom, who is actually putting out a lot of publication and work, many clinics treating women with testosterone. One of the largest clinics in the world is actually in the UK treating women with testosterone. And it's really just about awareness. We do know that if she's postmenopausal, there's a high likelihood that her testosterone will be low. And if she comes in with signs and symptoms of low energy, low libido, increased fat deposition, decreased muscle mass, some depression, those signs and symptoms could be of menopause, but they're almost the exact same signs and symptoms of a woman with low testosterone, right? And treating her with testosterone can help mitigate a lot of the signs and symptoms of menopause. I'm not underscoring the importance of HRT as well. Estrogen, progesterone are equally important, if not in many cases, sometimes more important, but it's the whole triangle. If you are treating just 2 points of the triangle, you're missing the entire picture, right? You need all 3 points of the triangle to make her whole again.
I hope that people listening will be able to take something from that. And I think it takes us along the road of supra-physiological use. And I wonder if this ties into the narrative and why maybe your job has felt so difficult at times because of concerns about performance enhancing and, even with the enhanced games coming up this month. I don't know if you've seen that.
Yes, I'm very familiar with them, yes.
Yeah. So might we talk
Let's
to
talk
some of
about that because most people, what we're in the business of, I'm in the business of, is taking people who are low and deficient and putting them back into the normal range, right? There are people who take testosterone who have normal levels and want to raise their levels even higher to super physiologic levels, and that's called doping, right? Now, there's something interesting that people should know about testosterone. There are what we call set points. So let's take example libido. If a man is low, let's just say 200, and I raise his testosterone to 600, and he says my libido is better, raising his testosterone to 1200 doesn't double his libido. Raising his testosterone to 1800 doesn't triple his libido. And in fact, when you get too high, you actually start seeing a decline in libido again. We call this the inverted U. So hormones love to be in balance, in the middle. Everything in life likes to be in balance. But if you get too low or too high, it's an issue. And the same goes with, for example, erectile function. If I double his testosterone to 600, 1200, the erectile function doesn't double. Bone mineral density doesn't double. Depression doesn't double in improvement, right? We saturate at a certain point, and doubling and tripling it does not make it that much better, but we think it does. The only exception, Jack, is muscle. The more T you give, the more muscle you can put on because you upregulate androgen receptors. And that can be addicting to many people, right? Because the muscle mass is important. And you see people in the gym. So I say you're not going to double your libido. You're not going to double your erectile function. You're not going to double your overall happiness in life or triple it by doubling. But yes, you can see some improvement in muscle. But then you start getting into danger because as you get into super physiologic levels, there are adverse events that you can experience, particularly cardiotoxicity, cardiomegaly, increased mortality. You have to be careful. And it gets addicting because when you start doubling, then you start tripling. With tripling, you start in trouble.
And what you just described there, very simply put, is the heart gets bigger.
Right, thicker. That's exactly right. Right. And increased mortality has been seen. Cardiovascular events have been seen at these very high levels. So you have to be careful. I mean, I don't advocate nor do I treat patients who want to put their testosterone at those high levels. I say that's not what I do. I will take someone who's low and put them into the normal range, but I'm not going to support super physiologic levels.
No, I really appreciate that as like an outlook, because that's my concern with the online clinic is that I was able to work with and around my experience. And I think you and I would promote that. And that's the benefit you have working with somebody one-on-one and going into a clinic and having that contact. And maybe a concern that people I work with, people who are in the NHS, have with private healthcare sometimes is that you can just pay for the outcome you want. It's like you can create the study to get the answer that you want. Doping is its own thing, but almost by stealth, that you're surreptitiously increasing something that doesn't need it, that could be aided with other interventions.
Right. And this is the easy way out, right? The hard way out is doing the work with the diet and the exercise and the sleep and the stress. But the hard way typically is the best way, and this is just give me a pill. And you mentioned something earlier, but your testosterone level, you said, was not really even that low. So you have to be careful. If it was low normal but not low, in a young man, you have to even be more concerned, because if he takes it and then stops, he will not typically come back to that level again. So if you were in the normal range, let's say you were 390, but you were low normal, and I give it to you for a long period of time, and then you decide, I want to stop, I can't guarantee you're coming back to 390. And you weren't doing so bad at 390. So you just have to be careful.
Yeah. And just while it's topical, peptides are a big thing in the gym at the moment. And, this is locker room chat. This is stuff that I'm hearing people on my level are taking. So there are people who are taking back market testosterone. I'm aware of that. And for a lot of people, that's cheaper than whey protein, but you can't necessarily guarantee the quality of it or even the
dosage.
Ingredients.
You don't even know. Yeah, that's
but
right.
Then we have peptides coming in as a new conversation, and people thinking, well, it's not testosterone. It's not labeled as something by WADA as an agent that could help me a PED. So surely it's fine. If a YouTuber says that they take it, then, I could look into that. What's been your take on that?
Peptides have been around for a long time, but it's a loose term. If you look at Ozempic is a peptide, right? There are many types of peptides, but when patients are talking about peptides, they're talking about specific types of peptides, particularly growth hormone peptides. Those are important. Sometimes we're talking about gastric peptides like BPC 157. They're talking about sometimes sex peptides, sex hormone peptides, such as PT 141. So there are different types of peptides, and each peptide has a unique characteristic that it may benefit you from. But you have to look at what's going on in the US right now, what we call categories. Category 1, Category 2, Category 3. Category 1 means you're allowed to compound it and make it. Category 2 means you are not allowed to compound it or make it because it is some safety concerns, danger. Category 3 means we're not sure, right? So in the US in 2023, 19 peptides went from Category 1 to Category 2, meaning we don't know if they're dangerous. We've taken them off the market. We're going to wait and see, right? And just recently, our FDA has announced that they will take 12 of them and they will assess them coming this, actually, I believe it's 7 of them coming in the next month. They'll assess whether they should come into Category 1. So how have patients been getting these peptides for the past 2 years in the US if they've been on Category 2? It's because they get it from the black market. And so you can purchase it for animals research. You can purchase it for research, but you cannot purchase it for human clinical use, nor can you produce it for human clinical use because of the safety concerns. But the workaround is that people have been getting on the black market or for research or for animal use and that using on your own. I discourage that. Anything that's on the Category 2 list, I would say that there should be caution until it's further investigated. These are made by compounding pharmacies. You don't know the quality. You don't know what's in it. And you don't even know that if it is truly that peptide, is it safe or effective? It's never been studied, right? Several have been studied. For example, sermorelin, it's FDA approved. It's been around for a long time. Testosterone, FDA approved. They both are here for muscle mass, fat, lipodystrophy, bringing down the central obesity, and they can help with sleep as well. FDA approved, been proven, I'm okay with that, right? The ones that are not FDA approved or on Category 2, I would urge caution.
Sure. And it's that thing of, I think, quick results, kind of quick come down or heavier come down is often what I find. It's the same with diets. It's the same with intense exercise. If you do too much of anything too quickly, there's going to be a rebound. And often, as you've already described, baseline isn't the same anymore.
Right.
Yeah. If you go up too quickly, you come down hard, and then you may never find what normal was for you again, which would be tragic.
It's important. But Jack, we don't know what the long-term effects are with giving people these newer peptides and the ones that are not FDA approved. We don't know. We don't know. We can't even compare because they're made from different compounding pharmacies. So you don't know if the first one's the same as the second one, the same as the third one. They could all be different, even though they say the same thing on the bottle, right? There's some standardization, but not great standardization on dosing and how often to give. You can ask many experts; they'll give you different answers. So then it's hard to run a trial on those. So if you said, Dr. Khera, can you produce the study that shows that this one is safe and effective? I would say, no, I can't produce it. There may be an animal study, but I don't have the data on humans. Okay, so then how can I, in good conscience, say it's safe and effective?
Maybe something that we can say that's safe and effective. Finally, we'll bring it back in. The Mediterranean diet. What is it about
Yeah.
this that seems to make sense for you? And if you'll run with me on it, I want to ask if it's not just the food.
Yes. So two things. It's not just the Mediterranean diet. There are many diets that could do this. There's the Persian diet. There's the DASH diet. There are many diets, but they all share a simple concept, right? And they're low on inflammatory foods. They're low on trans fats. They're low on saturated fats. They're basically healthier diets that focus not only on eating the right thing, but the right portions, right? Because portion control is a big problem, right? So if you can control, if you look at the Sardinians who eat the so there's 7 blue zones in the world. You know this, the patients that live the longest, right? And one of the keys is the diet that they eat. They maintain a healthy diet, and it's a pyramid on the Mediterranean diet. So on the Mediterranean diet, there's lots of grains, legumes, vegetables, and fruits. But as you get higher and higher in the pyramid, it is once a week or twice a week chicken or fish, and then once a month is red meat. But on the side of the pyramid, there is wine, and wine is acceptable. You can have a glass or two even a day inside the Mediterranean diet, in which is considered healthy. We'll talk about alcohol because I have my own opinions as well. But the reality is that, you know, the Mediterranean diet, if someone says, wow, there's a lot of pastas and whole grains at the bottom, and I was taught that that causes me to become fat and obese, and I should stay away from pasta because the Atkins diet says you should stay away. And there's a discrepancy you can see between what we call healthy diets and low-fat diets. They're not always the same, you know what I mean? And they can be different. The Mediterranean diet is just one example. The DASH diet, the Persian diet, really focusing on portions, focusing on staying away from fried foods, inflammatory foods, focusing on foods that are anti-inflammatory, blueberries or kale, things that really can bring down the inflammation in the body, I think are the real key. And what's nice is the Mediterranean diet has been studied over and over again in multiple disciplines. It's been shown to help with cardiovascular disease, reduce cardiovascular disease. It's been shown in sexual dysfunction to help reduce and improve sexual dysfunction in men and women. It's been used for diabetic retinopathy to show improvements as well. It's used for dementia, Alzheimer's. In major journals, we're seeing that these types of diets can actually be very helpful.
I went to a lecture about a month ago in Sheffield on the gut microbiome and
Yes.
the brain, and the link there, the idea that the gut is the second brain, and what we eat impacts our heads, you know, our outlooks, our mindsets, our moods. And I wondered if you were to transport a load of people from England to the Mediterranean, but kept their diet, and then took people from the Mediterranean and put them in England, but kept their diet, if then there would be a secondary effect of something else. So when we look at these blue zones, I've got 5 of them here. So we've got Loma Linda in California,
Yeah.
we've got Costa Rica, we've got Sardinia, we've got Caria in Greece, and Okinawa, and then Singapore was a man-made blue zone.
Yes,
I think it's
that's
more
right.
recently. And I'm missing one. Do you know what the other one is?
I don't remember the last one, but Loma Linda is the only one we have in the U.S. Did you say the one in Costa Rica, Nicoya?
Nicoya in Costa Rica.
Yeah. And then Sardinia, and then the one in Japan. I'm missing the last one, but I know that I thought there were 7. Yeah.
Maybe we'll find it
Yeah,
at some point
that's right.
outside of this.
Yes.
But what's happening in these places is that they're very close to the equator. And I've done an amount of traveling recently. I was in California in November last year, and the amount of light is very different compared to places like England. You know, there's a more consistent time frame of sunlight. So even though you might not have these long nights like we love in late spring and summer, you have consistent sunlight. So from 6 to 6 or 7 till 7. And I wonder if that has an impact on mood that we're not necessarily documenting. And vitamin D production, you know, people in Scotland are prescribed vitamin D because they get so little sunlight. And I think in England, we should have that as well. I take vitamin D as a supplement. It would be helpful if the NHS were able to give that to everyone because, you know, we need it. And then also with alcohol as a thing, we know it to be toxic, you know, and I've curbed my own alcohol consumption. I had a pint at the weekend and it was very nice. I had 2 half pints and that was enough for me. But, you know, I probably have a pint or 2 pints a month max because I know that alcohol as a whole, you know, it kills things. That's why we use it in hand sanitizer. And it's not necessarily something that is good for humans, even if it is normalized. But as you say, in the diet, in the Mediterranean diet, it is allowed. And so I'm thinking again, what is it about the Mediterranean diet? Is it just the food, which does have oils in, which does allow for sweets, which does allow for wine? I know Nonna in Sardinia, because I learnt enough Italian to chat to her, near San Teodoro. She used to love smoking. And she loves her fried pastries, but she's 89 and feeling good, you know? And what is it about that? Well, she has a purpose. She gets up every day to make pasta for the family, and Nonno will bring the ingredients for the pasta. These two are very happy, I think, because they've got a purpose and they see their family every day. They see a wider community.
Yeah.
I'm thinking that maybe that is a big part of the Mediterranean diet that maybe isn't talked about.
It's a huge part. So the Mediterranean diet is just one, but the purpose part, we always, even know with the Japanese as well, having a purpose in life can increase your longevity, period. Having a purpose in life can increase the longevity. But the other factors we didn't talk about were 20% genetic, 20% environmental, right? So those play a role. So there's an environmental role, what exposures we have to our environment. Genetics plays a role, but the majority, if you look at the pie, 50% is choices that we make. So whether you choose to smoke, whether you choose to eat unhealthy, not sleep. So those choices can make a big impact. But in terms of the choices, we're now narrowing it down to the food, right? And so you can see as that we keep narrowing down, the pie gets a little bit smaller and smaller, but it's important to impact to know that the food that these blue zones eat tend to be whole foods. I mean, if you look at the Japanese, I've been to Nagoya many times, and the concept is pura vida. Pura vida means a simply unprocessed, pure, clean food, right? And the portions are not large. When we get served and we go down there, they're small portions, right? And in America, we have this concept called supersize. I can go into any restaurant in my hometown, any restaurant in America, and take the meal I get, cut it into a third, and it's enough. Honestly, it's enough, you know? And so you just have to be careful on the portion size as well. But so I think you're right, Jack. It's multifactorial. We're talking about the diet, but we didn't talk about the genetics. We didn't talk about the environmental exposures. And there's other things called choices that can affect your longevity. You know, I always talk about this. There's several concepts. There's called health span, lifespan, and now sex span. Lifespan is how long you and I are going to live. That's great. We're going to live a long life, hopefully. But we want to be healthy until the day we die. So you and I want our health span to last as long as our lifespan, right? I don't want to live till 90, but be debilitated at 70. That's not the way I want this to end out, right? And the same goes with sex span. Sex span is the portion of your life where you'll have the ability and desire to engage in sexual activity. And Jack, most of us want our sex span to last as long as our lifespan, right? I mean, we don't want to live till 90, but be able to have sex only till 50. It would be very unacceptable to many of us, you know? So we're trying to increase our lifespan, health span, and sex span to all meet at the very end. And that's very, very important. And the choices that we make today dictate that. So if a man comes to me at 40 and he gets it, he understands diet, exercise, sleep, and stress today, it's called an annuity. Now I have time to actually build up his health span, lifespan. But if he comes to me at 75 and says, I'm not doing well, diabetes, uncontrolled cardiovascular disease, and I'd like you to increase my lifespan and health span, I say, it's too late. Right? It's too late. You're coming to me at a very late portion of time. I'll do my best, but it's going to be very too late. I want to give you an analogy because I always like to use an analogy. Okay. I think of it like a plane. A plane is going up in the air. At some point in our lives, no matter how hard we work, the plane engine will turn off, right? And you will then only be able to decrease the slope of the plane, right? So that's called my health. And if I take my health very seriously and I get to 36,000 feet altitude and the engine turns off, I'm very high, and I decrease the slope, I'll be fine because my health span will last as long as my lifespan. But when the engine turns off, if I am at a low altitude, I'm in trouble, right? Because I don't have much room until I go down. And so my goal is to have younger men get it at an earlier age, increase that altitude so that when the engine turns off, you're fine. It'll be a nice glide down, but your health span will last as long as your lifespan.
Amazing. I really like that as an idea that we're essentially trying to make the best choices for us tomorrow, aren't we? We could make it so much smaller than don't even think about 70, 80, 90, think about tomorrow. Would you tomorrow be happy with the decisions that you today made? Yeah.
Right. I think it's really important. And I give a lot of lectures to people in finance. Even my son is trying to go into finance. I said, look, there's a concept in finance that all of you have understood very carefully. You've understood the concept of investing early. So if I'm 20 years old and I put $100 a week away every week, when I'm 80 or 75 years old, it's a lot of money in the bank just with $100 a week. If you decide at 65, you want to start putting $100 a week away, you don't have time on your side, right? And that's a problem. It's compounded interest, right? Well, your health is also compounded interest. It's the same analogy. The sooner you start, the more you'll have at the end, right? But many people start too late. They don't think about their health as compounded interest.
It has become so much bigger than just testosterone, which I love. And the field that you specialize in is obviously so much bigger than that when you take in the person as a whole and don't just treat the number or the symptoms. But I'm just thinking, Dr. Khera, what don't you get asked? What would you like to talk more on? What kind of wakes you up in the morning and pushes you?
Yeah. It's the patients. I do a ton of research. The research drives me. The teaching, I have a lot of medical students and residents. It's this whole field of promoting this field. I want to destigmatize sexual health. I think people think of sexual health as something they're embarrassed to talk about it, but it's such a common condition. They need to understand that sexual health is a warning sign for men and women that something else is going on and you should get treatment. But I think that's a really important thing to realize. I also, we talked a lot about, I came up with a concept called offense and defense because everyone knows what offense and defense is. And I only have 4 elements on both sides, 4 on offense, 4 on defense. Very simple. Offense is anything, Jack, that moves our health forward. And the 4 things on offense we've talked about are diet, exercise, sleep, and stress reduction. That's going to move my health and your health forward. But we didn't talk about defense. And defense is equally important. And statistically, there's an 80% chance that there's only 4 ways you and I are going to die. That's it. 80% chance. Either we're going to get cancer, heart attack, metabolic disease, meaning diabetes, obesity complications, or neurodegenerative Parkinson's or Alzheimer's. That's it. 80% chance. So Jack, if you know that today, I'm telling you how you're going to potentially die. Shouldn't you do everything in your power to keep those things away? You should. You should be doing everything you can to screen the cancer. You should be everything to screen cardiovascular risk. You should be screening for diabetes, obesity, metabolic syndrome, and we can talk, there are many ways to do it. And there are ways to now even screen for Alzheimer's and dementia. So, we should be screening and preventing the bad things from happening. Equally as important is moving the health forward on offense. And I tell the patients, sometimes a phenomenal offense is a great defense, right? It is, but don't forget the defense. It's equally important in my play.
I've never had somebody say as politely as you, Dr. Ma, if I tell you the ways that you're going to die.
Yeah. It's
You've really
true,
tickled me with that. Yeah.
Yeah. We know statistically this is what it's going to be. So if I know that today, if you gave me that information, I should be doing everything I can to keep those things away from me.
The ways that you mentioned, you said that there were a couple of ways that you could screen things or look out for things.
There are recommendations from national guidelines, for example, colonoscopy, PSA check, mammography, pap smears. You make sure that you get those done and you make sure you get them on time. You don't skip them. Some of the biggest problems that we see are patients that say, I had to skip my colonoscopy and now I have colon cancer. You need to be diligent. Those are there for a reason. And many people have lowered the bar. Usually we used to say 50-year-old for colonoscopy. Now it's 45 and now even 40 years old. Starting earlier does not hurt. You may want to start, but if you're at a high risk. There are other things that we do in the United States that potentially could be a nice screen. In the US, some people are using full body MRI. It's not necessary. I'm just mentioning that it is. There's also Gallery testing, which is a blood test that looks. There are other ways. There's new things down the pipeline that are coming out, blood tests that are phenomenal for screening for cancers. I also think it's important to screen, at least for cardiovascular, looking at things like your ApoB, LP(a). These are blood screens for cholesterol. Some people are getting coronary calcium scores just to look at the heart, just a little bit step further. I do believe that using what we call a CMG, it's called a continuous glucose monitor, just for a couple of weeks to learn about what foods are bad for you and good for you are very important. I wore one for about a month just to see what the foods that I thought were very healthy. I was wrong. Some of them spiked my sugars like you can't believe. My wife and I would eat at the same restaurant with the same food, and we would have different numbers. Mine would spike and hers wouldn't. So there were genetics involved as well. But you learn a lot with CMG. So, I mean, there are things you can do to help keep those things away. Again, a good offense is a good defense, but please screen for what I call the 4 defenses.
I think you said something really interesting there that, for instance, if you and your wife were both to eat blueberries and one of you saw a bigger insulin spike, the insulin spike isn't of itself a bad thing necessarily,
Right.
provided that you are able to handle it, through homeostasis and natural
Sure.
bodily production and function. But also that what we're talking about there, I think, is a broader point that you've already raised, which is that we are unique, that we need
right.
different things. So while we may see that spike and that could be concerning in the context of, say, sport, if I eat a banana before
Yes.
exercise, that's very deliberate from me because I'm wanting
Right.
this to happen,
Right.
But if I'm going to bed, I probably don't need the same spike, although actually carbs before bed could lead to better quality of sleep. That's a different discussion.
That's right. Yeah.
But the notion that we are different, we could all get scanned, we could all find out a little bit more about our bodies. Just because we got a car doesn't know that we know internal combustion inside out,
Right.
We might have a
Right.
license, but we don't know how the car works. So why not find out how the car works? Why not do the diagnostics if you've got access to them? I think in the UK, maybe it's easier to get basic functional tests. In the US, is it easy for people to
It
get a
is.
baseline?
Yeah, it's easier and easier. And even if you don't have insurance, you can pay cash, and the cash price for these tests are now very cheap. There are many companies that are coming out getting a whole full battery of labs for just $100, and they ship it to your house. So there are many companies now that you can get tests. And you said something important. I'm a big believer in metrics and measuring. And you can do that. I think it's important to measure your sleep. I don't care if you use an Oura ring, you Whoop, 8 sleep mattress cover, measure your sleep. You can measure your sugar, measure your blood pressure. You can measure your heart rate. Measurements are so useful because if you can't measure it, you can't improve it, right? You really want to have a metric. And I think measuring sleep can make a big, big difference. And in the nights where you have poor sleep, write down what you did. What time did you go to bed? When was your last meal? What was the temperature in the room? Right? The nights you have a great sleep, write it down. And these are ways to improve diet, exercise, sleep, and actually stress.
For sure. And I want to add something based on my client experience, if that's all right, is that all of these data points are fantastic when they're taken with the idea of the person as a whole. So
Yes.
I've got very basic sleep tracking for my clients. It's just a score 1 out of 10. How did you sleep? And then how was your
Okay.
energy the next day? How was your mood? And if people had a bad night's sleep, but their mood was still okay the next day, I want people to pay attention to that because I worry sometimes that people see bad sleep scores and then think, oh, well, that's my day ruined. Whereas
That's true.
actually,
That's right.
like a swallow doesn't make a summer, one bad night's
Yeah.
sleep doesn't ruin a week, doesn't have to ruin the
Yeah.
day. Can you
Right.
take that data and think, okay, cool. As you said, the room was a bit too hot. I drank a little bit too much liquid close to bedtime. They're the
Yeah.
things that you improve. But once that's done, the sleep's gone now. How do you look forward? What can you add into the day to make it better for tomorrow? You would be my approach.
I like it. I like it a lot.
Yeah.
I like that a lot, actually. I tell patients every day when you wake up and every night when you go to sleep, ask yourself, what are you going to do to improve your diet, exercise, sleep, and stress better than yesterday? Better than yesterday. Because all of us can do better. Even you and I, Jack, and we can do better on all 4, right? And so what are we going to do today better than we did yesterday in all 4 of these?
Love that. Can I ask one more question before we
Sure.
bring it
Sure.
home? You've been right and early before. What belief about testosterone or sexual health that people have today do you think will be outdated in 10 years' time?
I want you to think about it in 3 categories. First, for example, let's say cardiovascular disease. We were first taught that low testosterone increases cardiovascular risk. Then the second bucket was, if I give you testosterone, is that going to be dangerous and increase cardiovascular risk? And the Traverse trial, which was published, said no. Now we're getting to an era where if I give you testosterone, can I reverse or improve your cardiovascular disease? We're not there yet. We're in the third era. And that same era is same with prostate cancer. Is it safe? Can we give it to you? Now we're saying, can we use testosterone for therapy for prostate cancer, cardiovascular disease, diabetes, right? That's where we are today. And it's an exciting era. A lot of studies are getting done. The T40M, which is a big Australian study, 1,000 men, phenomenal study, show that giving testosterone actually reduces diabetes and reduces the progression to diabetes. Phenomenal, the first of its kind. So we're getting into an era where we can now talk about testosterone, not about safety, but as a therapeutic agent to help preserve or treat many of these conditions. And that's very exciting because that's where we are now. And I would say that What's also very exciting is testosterone for women. You know, we are now getting into an era where we are now trying to get this awareness for women, get them treated. And I think many people still have this fear that testosterone is harmful for women. And I think that needs to change.
And based on your own research, publications, is there anywhere that you want to send people? The Testosterone Project, I thought, was a really nice resource that I looked at
Phenomenal.
before.
It's a great resource.
Yeah.
The Testosterone Project is always up to date. It's giving people up to date data on what we're doing politically, in government, how you can get involved. It's more US based also, but we also have great information on testosterone for men, testosterone for women, what's coming down the pipeline. So if you want great information on testosterone, it's a fantastic reference. My website is drmohitkhera.com, and there's a patient resources section where I go through many types of different resources on there that you can look at and click the links and take you to as well. So I think those are some excellent resources.
Thank you so much for your time on this.
Thank you, Jack.
Great to catch up with you.
It was a pleasure. Thank you so much for having me on the show.
So we'll end it there. Sincerely, I really enjoyed that. Thank you.
Yeah, it was great. It was great. It looks like you really did your homework. You knew exactly the things I've done before. I was like, how does he know that?
If you enjoyed this episode of Fitness and Thinking, please do leave a like, comment, and do subscribe if you haven't already. Lots of people will watch an episode or two but not hit that subscribe button, meaning that they miss the future episodes, meaning that maybe to those algorithms it doesn't look like they're that interested overall in the project. But I get the sense that more and more of you are. We're into triple digits in terms of followers and people tuning in both for the podcast and the newsletter. And even this cat is checking us out. Yeah.